bowel obstruction. Okay, let's go again. What can cause a bowel obstruction?
Volvulus.
Okay, volvulus. What does a volvulus mean for those that don't know?
It's like twisting of the intestines.
Yeah.
And then
So you can get a volvulus like we were just talking about in the hernia situation from an internal hernia too, right? So we could talk about volvulus as a whole thing. That'll be good. What else can cause a bowel obstruction?
Adhesions.
Okay, intussusception. Yeah, you guys are listing all the crazy stuff here. Intussusception. I heard the common one. Okay, the most common reason for a bowel obstruction is going to be adhesions. Okay, and why do we get adhesions? Surgery. So we did surgery. There's scar tissue, just like if you cut your skin. Inside the abdomen, there's scar tissue as well. So adhesions is going to be your number one. Okay, what else?
Strictures.
Yeah, we'll call it stricture, a little weird, like a weird adhesion, if you will. But sure, we could say that. Again, you guys are being weird here. Give me some normal stuff.
They have like non-mechanical.
Okay, also weird. Okay. Okay, yeah, like non-mechanical. Sure, we're talking about mechanical stuff, but you want to tell me about like a Ogilvy's syndrome, or like what's the other thing we commonly see in like maybe a post-op patient, a little slow. Yeah, like an Ogilvy's, like an ileus. Okay. Okay. Go back mechanical. What did we just talk about? Hernia. Okay, polyp, but what's more scary or that I'm worried about?
Cancer.
Yeah, cancer, like a mass. Okay. Mass.
What
Cancer
about
like
like a physical object? Like a
Sure, a foreign body. Actually, that's a good one. Yeah, sure. Foreign body. You ate something. Or in kids, what's it called in kids if they like were eating like hair? Yeah, Bezor. I did it. That was the first operation I ever did on pediatric surgery. I did an X-lap and a gastrotomy on a little kid and literally opened their stomach and then just pulled out a massive hairball. Oh, it was gross.
That's great.
Yeah, instant gratification there.
We had that up in Nemours, and the hair that was found was not the hair color of the patient.
Oh, interesting.
So it's just
Well, they eat these. So like these kids have the, I don't know the disorder that it's called, but they eat.
like pica.
Yeah. Pica. That's it. Yeah, exactly. All right. What else causes a bowel obstruction? And so bowel obstruction, maybe I can classify it into what other kind of two ideas or areas.
Small.
Yeah, maybe so I could say it's a small bowel obstruction or an SBO, which is what we most commonly deal with, or like a large bowel obstruction. What is the impending issue in a bowel obstruction, no matter what it is? Yeah, so at some point, the bowel is going to distend to where it's going to become ischemic, basically, is what really... You got to think of these concepts because they just repeat themselves. If I have pressure on the bowel wall, I'm going to first, because it's a low pressure system, impede venous outflow. So the bowel is going to really, at the end of the day, perforate because it's becoming necrotic. Okay, it's dying, right? So eventually, it's going to perforate. Okay. How do we go about, so a patient comes in, they've had numerous laparotomies in the past. How do we go about addressing this issue? What do we do?
It would depend on if they're stable or not.
Okay, good question. Okay, great, excellent. I love that you said that. Okay, so you go down to the ED. Their vital signs are stable. Okay, heart rate's 75, blood pressure's 120 over 80. They're sitting there looking at you. They're on room air. You examine them. They're mildly distended, a little tympanic. What scan do we want to get?
CT.
Yeah, so these people are all going to get a CT scan. Okay. All right, so then on the CT, it says small bowel obstruction. Now what?
Let's start with a conservative management since they're not
Yeah.
hemodynamically unstable.
So conservative management, what do you want to do?
Maybe try like some laxative.
Okay, so is a laxative going to help an SBO, a small bowel obstruction?
You can use antibiotics for some causes, no?
What are we going to do? Yeah. So let's go down that road. So we're going to make them NPO. We're going to place a nasogastric tube. We have our whole discussion on NG tubes to low intermittent suction, and we're going to confirm its placement, right, after we put it in. What else is important in this patient population here? Guy says, been feeling like crap for a week, man. Haven't eaten much, haven't pooped in 2 days, and I've been vomiting like crazy.
Nutrition, parenteral nutrition, or enteral nutrition.
Yeah, so nutrition, sure, but
Fluids.
yeah, electrolytes. So our biggest concern here is their fluid status, right? So we need to get them on some IV fluids, and typically, initially, that's going to be what we describe as resuscitative fluid initially, which is typically lactated ringers or normal saline, and then we're going to transition them to then maintenance fluid, which is typically half normal saline with 20 milliequivalents of potassium chloride. That's the typical resuscitative versus maintenance fluid, okay? All right, then what study do we typically get the next day? Yeah, we call it an SBS, a small bowel series. So we basically give them some oral contrast, and we see what happens, okay? So you get your SBS, and it shows just a dead-end street. So contrast goes, and it stops, and nothing gets its way to the colon. And the NG tube put out a liter of bilious output in the last 24 hours. What are you thinking?
Surgery.
Yeah, so this is probably somebody that's going to need to go to the operating room. So we would do, typically, an exploratory laparotomy, and then that would then be considered an open enterolysis if it was indeed secondary to adhesions. We would see whatever's going on, and we would free the intestine, and hopefully that would resolve their bowel obstruction. And unfortunately, that predisposes them to more adhesions in the future, kind of like a vicious cycle, but that's the best we could do. All right, what if somebody comes in and for some reason the ED ordered a KUB, and on the KUB their cecum is 10 centimeters. We measured it. What are you suspecting here? And this is an 80-year-old that has never had a colonoscopy before.
Cancer.
Yeah, so probably an obstructing mass. Are you concerned about the size of the cecum?
Yes.
Yeah. So there's this thing called the 3-6-9 rule. Anybody? So 3 centimeters small bowel is when we get concerned. 6 centimeters for colon in general is what I always say, and then 9 centimeters for the specific cecum. So this person's on the verge of perforating. They need an operation, okay? Now, say you go in there and you see a sigmoid mass, you resect it. What are your options there then?
Like a power penny collector.
Colostomy. Would you put them back together?
No, don't you have to hemicolectomy?
Depends.
Yeah. This person, you probably would most certainly not put them back together. And one of the main reasons would be there would be a mismatch. So their rectum would be in distal sigmoid, depending on where this cancer is and depending on what you did for your, quote, oncologic resection. And that's the other big difference. Someone comes in elective for an elective cancer operation, you do kind of like an oncologic resection. Someone comes in perforated, obstructed, chaos like ours, not my elective ones. It's like you're just doing what you got to do because the mass is either bleeding, that's one good reason to take them to the operating room, or it's perforated. That's the other good reason, or on the verge here, right? But so that mismatch, the fact that the colon is not prepped, there's multiple reasons why this patient, I would be very hesitant to put that patient back together.